Good evening, everyone. Welcome to this IC-8 webinar. It's my pleasure to chair this evening's webinar. It's going to be about 1 hour, so we're going to have three speakers. There's going to be Dr. Alex Poon from Melbourne, Dr. Greg Moloney from Sydney, and myself from Singapore. So I want to thank you all for basically attending, and also thank Greg and Alex, because they're 3 hours ahead of us, and I know they're probably going to be awake for another 4 hours anyway, but it's about 10 p.m. now in their time, so thanks for being a part of this webinar series. So without delay, we will start with the first speaker. Is going to be Alex Poon. He's a consultant with expertise in cornea and external eye disease, and a member of the corneal unit of Royal Victoria Eye and Ear Hospital since 2000. His general ophthalmology training was in the same hospital and also in Sydney, and he took and did subspecialty training at Moorfields Eye Hospital under the direction of Dr. Jod Mehta. And he has an interest in refractive, cataract, and corneal surgery, and he'll be presenting on his experience on enhancing monovision in myopes. Thanks, Alex.
Thank you. Just sharing the screen.
Yep.
It's all good?
Yep, good.
Yeah, great. Thank you, Jod and AcuFocus for inviting me to speak tonight. Big hello from Melbourne to everyone. I think Singapore, Japan. Let's start. Okay. I think you all agree modern cataract surgery is now basically a refractive procedure. Patients want a spectacle-free solution, and also for presbyopia as well. You know, people in the past, we've tried monovision. More recently, diffractive technology with in trifocals and EDOF lenses been used. Each have their own disadvantages. A newer technology, X-Wave technology by Alcon, Vivity, haven't had much experience with that, but I could say that universally, none of them give great results for near vision, particularly for low myopes, because low myopes generally are used to clear unaided near vision before the cataracts came on. So AcuFocus as a company started with small aperture technology in their camera corneal inlay. The idea with the small aperture is something we're all used to in our clinics, using the pinhole to extend their depth of focus. But I think they've now put it in the right place. They've embedded it into a hydrophobic lens, and we place it inside the eye after cataract surgery. And it's been promoted with monovision to provide both near and reasonable distance vision. And so just this graph shows a depth of focus curve, courtesy of AcuFocus. The purple line shows what a monofocal depth of focus would look like, with the target about -0 to 5. If you look at the 20/30 line or the 6/9 line, the depth of focus is about 1.5 diopters. So then if you look at the blue line, which is what you would get with a small aperture, as in the IC-8 lens, it extends the depth of focus in that 20/30 range to about 3 diopters. So then if you go further and do monovision, so this red curve is now the binocular curve. With monovision, the plano eye is, so the monofocal eye is targeted plano, and then the IC-8 eye is targeted -0.75. It just extends that curve further, and it gets to a point where the +3 add vicinity of near vision is capable. I'm going to present my series of myopes who've had these implanted. All my patients have had monovision trialed with contact lenses. So we know that they can tolerate up to -1.25. I performed the dominant eye first with a plano aim. The IC-8 lens was implanted in the non-dominant eye with a target of between -1 to -1.25. Note that this is a little bit higher than what AcuFocus encouraged at their release. And patients with other significant ocular disease were excluded. I chose patients who had pupil size of 5.5 millimeters or smaller. All patients had at least 5 months follow-up. And to examine their dysphotopsias, McEllenden's quality of vision questionnaire was used. And we also asked questions about spectacle use and their satisfaction. So not a large group, 25 patients, average age about 60, mean follow-up 9.5 months. The dominant eye had a variety of lenses put in, basically with a plano target, and any sill of over 0.75 was treated with a toric lens. The non-dominant eye, I inserted the IC-8 lens. So if we just look at the pre-op refraction, this really is, this is the mean manifest refractive spherical equivalent. So you can see it's a group of patients with low to moderate myopia. And the magnitude of astigmatism range from 0 to 2 in both eyes. And if you look at 6 months, with the IC-8, we targeted using the Barrett Universal 2 formula, as we said before, 1 to 1.25 myopia. At 6 months, this was the mean spherical equivalent, and this was the mean astigmatic power of the IC-8 lens. In the dominant eye, it was pretty much spot on with the mean of very close to plano and very low astigmatic power. So let's have a look at some visual results. This is an uncorrected distance visual acuity at the last visit. One would expect the dominant eye to do well, and they did. But the mean of the IC-8 eyes did very well as well. They also, uncorrected, they saw 6.9 as a mean. If you have a look at this chart on the right, the green column is the IC-8, the dominant other eye is yellow, and red is both eyes. So all patients saw 6.12 from both eyes. Obviously, the dominant eyes saw a bit higher levels of acuity with the IC-8 eyes between 10 and 20% saw 6.6. About 92% of the patients had best corrected distance visual acuity of 6.6. So at the end of the day, not all patients had 6.6 vision, which might account for why some of the dominant eyes did not see better than 6.9. So with the uncorrected intermediate visual acuity measured at 60 centimeters, one would expect the IC-8 eyes to do very well. And they generally did. The mean was 6.6. The fellow eyes were starting to drop off at 6.12 as a mean. If you look at this graph, the IC-8 eyes did quite well. 6.75, greater than 90%. 6.6, about 65%. looking at the near visual acuity, uncorrected near visual acuity, I think at 30 centimeters, IC-8 eyes did very well, 6.9, which equates to about N5 mean. Fellow eyes, as you expect, would not do well, but basically over 90% seeing N5, which is great, I think. In regards to the dysphotopsias, McEllen's questionnaire is well validated, rash tested, commonly used to assess intraocular lenses in refractive surgery. It basically asks patients to rate 10 different types of distortions, glare, like as in here, halos, starburst, haze, blurry vision, distortion, and double vision. And the patients get these pictures and they get to rate them in three manners. One, the first is how frequent they are, and it goes from 0 to 3. And you can see the mean scores for each of the patients were very low, meaning they're not very frequent. So the second question for the same distortions was how severe the patients rated it, rating from not at all to severe. Again, the scores were quite low, below 1, suggesting not very severe. The third is how bothersome these dysphotopsias were. Same kind of questions, not at all, a little, quite, and very bothersome. Again, very low bothersome scores. I looked at it in a slightly different manner. I picked up the bothersome scores for dysphotopsia symptoms, glare, halos, starburst, and hazy vision, and looked at the percentage of patients for each of those scores. So essentially, most of them had very little or not at all for these dysphotopsias. I then looked at an article by Monaco published in Ophthalmology. It's quite unfair to compare the two populations because they're very different populations. But I think if you look at it just in general, I would say the IC-8s possibly had a little bit more glare compared to the Zeiss and Alcon lens in these charts. So the Zeiss is the Zeiss Lisa is the blue and the Alcon is the red bars. And also the IC-8s probably had less halos than the respective multifocal lens. I think what you can take away from this is that IC-8s do have dysphotopsia symptoms, but they're generally pretty mild, and probably saw less halos with IC-8s than the diffractive type multifocal lenses. How would you rate your dependency on reading glasses? That was one of the questions asked, and 75% said none or little. It's possible that patients in dim light didn't see as well for reading. And how satisfied are you with your overall vision? Very satisfied and satisfied. So, of course, this is quite dependent on pre-op counseling and patient selection, but it was really good to see that patients were happy. So other considerations, I was a little bit surprised when I saw a really high rate of YAG capsulotomy. And afterwards I thought it's probably because it's a very small optical zone and you like that to be really clear with no opacities. A small opacity is an optical zone in the IC-8 affects the vision, whilst the same opacity in a normal IOL will probably have much less effect. So that's how I would explain why I have such a high capsulotomy rate. In one patient, I had to do it twice, most likely because I generally do the capsulotomy through the small pupil, and this was a young patient, and it grew back. And after a year, I had to repeat the capsulotomy. Some patients had some visual complaints, as we discussed before, halos and starburst driving at night. I found that with these patients, spectacle correction helped, and using myotics such as alphagan and pilocarpine also helped these symptoms, suggesting that light was coming in around the edge of the opaque disc, and these measures helped. Shadowing in dim light, some patients reported seeing kind of a shadow, I guess compared to the other eye in dim light, because the small aperture eye wasn't getting enough light in it. No patients required IOL exchange. So I like to conclude, enhanced monovision with the IC-8 eyes provides a good range of vision, particularly if you target about -1 to -1.25. I think with that target, you do get actually very good reading vision. But I think the bonus is that the distance vision is actually quite acceptable as well. Unlike monovision with the traditional monofocal lens, when distance vision is poor, with this, all of them still 6/12 at least. Visual dysphotopsias do occur. They're considered mild and not bothersome, and usually at night. But they probably have less halos compared to the diffractive options we have. And more importantly, we had very satisfied myopic patients. So thank you. It's been pretty isolated in Melbourne, and so it's been great to be with you all tonight. Big hello from Melbourne. Hope to see you in person in the near future. Thank you.
Thanks, Alex. Just to remind everyone of the participants, if you want to ask any questions, just basically go to the chat box and put your questions basically on there, so we can basically ask the speakers. Alex, while we're waiting just for that, and then we'll move on to Greg's talk. Let me ask you a quick question. That you mentioned about a little bit of some of the side effects especially at night time, and I've had that as well, and I've treated it with a bit of mitotic agent. And the only person I've actually had it with was somebody quite young, actually, a 43-year-old that I used it in, because he was an atope, and in the other eye he had monofocal cataract. How old was your patient that you used it on? How often have you seen that?
I've used myotics in about 2 patients.
Okay.
And it's worked well. They're both relatively young patients. In one of them, I also gave him some glasses to drive at night, and that actually helped as well. Okay. So presumably it's that it's the light coming out around the edge that was not captured by the small aperture. That was causing further aberrant light, I guess.
I mean, I've also noticed that if you give the mitotic agent, it also picks up the distance vision in that patient as well. Which is quite interesting. Just reducing the amount of light around the scattering is really having an effect on the distance vision as well. Okay,
that's great. Right.
So we'll move on to the next speaker, who's Greg Moloney from Sydney. So Greg, while you get ready with your slides. So Greg, just a quick introduction. He's published numerous peer-reviewed articles and presented internationally and nationally. I think his big claim to fame, however, is winning the first prize in Asquith 3 years in a row in film festival, which is quite an achievement. And also, I think of note, he was the 2018 recipient and the first Australian recipient of the Troutman Award, which I was happy to be part of the team who selected him for that presentation from the Corneal Society in the US. He currently works as a corneal and oculoplastic surgeon in Sydney Eye Hospital and a lecturer in Sydney University. He's going to be talking about his experience with IC-8 in corneal patients. Okay. Thank you, Greg.
Thanks, Jod. I presume you got that, that bottle of wine that I sent you before you made the panel selection of the Troutman. Did that get through?
I'm still waiting for it by boat, is it?
Oh yeah, okay. I'm just getting this going. Is that sharing okay?
Yeah, that's good. We got it. Yeah.
Okay. So, Jod, there's not much. There is a little bit of new content since I last gave this talk that you heard. So I apologise if I'm saying things twice to you, and I hope that it's of some use to the audience if you haven't heard me speak on this topic before. I think Alex's talk, thank you very much for that talk, Alex. I thought it was excellent, and it echoed a lot of the sort of experience that I've had as well with the lens. I'll talk a little bit more about my experience, I guess, with more irregular corneal patients, and where I've found this lens fitting into my practice so far since we've been playing around with it. These are the clinical situations that I've used the IC-8 in so far from a corneal perspective. Post-DWEC or DSO patients, post-DMEC patients. Most interestingly, and one of the most successful scenarios I've used it in so far is in keratoconic patients who are coming to cataract surgery in later life and are dependent on rigid contact lenses. And Alex has given a good talk on the routine cataract patient coming to surgery looking for presbyopic solutions. And if those patients have an aberrated cornea that you don't think is suitable for a diffractive lens, there are some cases that I've used that in as well, and post-radial keratotomy coming to cataract surgery as well. I last gave this talk to a more general audience, and I think, and it may not be necessary to make some of these points, but one of the early opinions I was asked about whether a patient with the cornea in the very blurry topography on the left there would be suitable for an IC-8 lens. The first point I make to people using pinhole optics to treat an irregular cornea is you have to make sure that the source of irregular astigmatism isn't very easily addressed at the location of the cornea without needing to exploit any pinhole optics at the time of cataract surgery. And the obvious example of that is really any pre-Bowman's source of irregular astigmatism is easily addressed with a superficial keratectomy. So that's a point that I make whenever I talk on this lens, is that make sure that you're not missing an easily treatable source of irregular astigmatism in the cornea that doesn't need pinhole optics. And the obvious example we all come across in regular clinical practice is a pterygium. So far I haven't been putting this in, although I've had, since I last gave this talk, I've had further talks with my retinal colleagues, but about whether they would support or advocate against this lens in patients with retinal disease. But so far it is still a subcategory of patients I'm avoiding, particularly diabetics, although it seems to be less and less that diabetics get treated with laser anymore. But still, that is even though this patient was a keratoconic who I was considering using the IC-8 in, they were also a diabetic with clinically significant macular edema, and that was something I just check and avoid in the corneal patients that I'm looking at. Alex gave an excellent talk about the sort of optical side effects and the dysphotopsias that this lens can produce. I think that my experience has been that, yes, there are, I would echo what you've said there, Alex, that yes, there are some patients who will complain of the sort of usual dysphotopsias that we can see with sometimes any lens. So starbursts and some glare. But the big side effect that I counsel for pre-surgical pre-surgery is the reduced contrast sensitivity in low light. When they lose that ability to have a dilated pupil and capture incident light in scotoptic conditions, that is when I found patients can find that this lens produces sort of some of the side effects that are worth talking about, and that's not often captured in some of the more standardized questionnaires for other types of lenses. So, you know, the typical complaint that I say and the sentence that I say when I'm talking to patients beforehand is that, look, if it were just up to this eye to find your way to the bathroom at night with the lights off, you would find it hard. And that's the sort of activity of daily living that's most commonly described to me independently by patients with an IC-8, that when I get up at night and all the lights are off, it's hard to see with this eye. And I just warn them about that before we go ahead. To be honest, that was the cause of the explantation that I've had to do with an IC-8 in this patient that I'm showing here. Jod and Alex had a quick discussion about the possible capture of light, or sort of a polychoric phenomenon in patients with a mesopic pupil that is slightly too big for this lens, and we preoperatively check for a mesopic pupil size of less than 5 millimeters, and we counsel heavily if we don't think that that's going to be the case. Having said that, the patient in this photo was a keratoconic who had such an improvement in their vision as a result of the surgery that this wasn't something that they complained about. The general advice I give to patients, and Jod and Alex, you've said sort of one patient's complaints from this phenomenon was solved actually simply by just giving them the advice that if you're sitting down to read, make sure you're doing it with quite bright light, and not just on the page, but maybe in the room as well. And if you're watching TV at night, maybe have that extra light on in the room and see whether that solves your problems, and that might be all you need to do. The size of the cartridge, if you put, I don't know whether the presence of this clinical sign post-surgery is correlated with any extra incidence of dysphotopsia, and I don't know whether Jod and Alex, you've also noticed this as well, but some of my patients, you'll get folding of the sort of the inlay with little creasing at the point of, or at the edge of the optic aperture. And I don't know whether that's because you're putting it through a cartridge that's too small. So I tend to favour, although the company will recommend a C cartridge as being a possible inserter, I tend to go with a B cartridge. I don't know what you guys do. But just to try to avoid excessive folding of that optical apparatus. I've had an increased success or sort of a better chance of centering this on the pupil since I've been using centration software intraoperatively, just to make sure that you're not landing off target. I use the Varion system with the visual axis as the target point for for this lens, as I do for most of my intraocular lenses that have an optical zone. The other big point to make is that this will provide sort of a landing zone for astigmatism and spherical equivalent, but it won't get rid of. It's still possible to have quite a high amount of astigmatism in a very irregular cornea, irregular astigmatism that can still occur within a 1.6 millimeter zone of the cornea, which is what we're isolating here. So it may be necessary. You can't rely just in a highly irregular cornea. You can't rely just on the AcuFocus to mop up all of the refractive error for you, and you may be forced to look to a second refractive intervention in some patients, either a piggyback lens or a topography-guided laser procedure to the cornea. And this is a series that, since I last presented this, there's been another patient that we've added to the series of patients who we've had to do just that. So these are keratoconics who have been in rigid gas permeable lenses as a visual solution their whole life, but now in later life have come to cataract surgery. Our strategy, and we discussed this at the last webinar that we presented on this lens, our strategy has been to try to reduce the refractive error to low myopia with the AcuFocus, the IC-8 lens, and then as a second stage, perform a topography guided PRK with minimal tissue ablation required due to that minimised refractive error. And the results of that two-step refractive intervention for rigid gas permeable lens-dependent keratoconics so far has been really pleasing. We've had all of our 4 patients who have finally come through that sequence have gone from dependence on hard contact lenses to spectacle independence for distance vision. Reading vision is acceptable and useful. No one's reading N5. The refractions are all close to plano. But this is a very, very happy group. 4 of the happiest groups, 4 of the happiest patients that I'm treating at the moment who've had that combination of interventions. The other patient that I'm happy to use this lens in is, as suggested, the patient perhaps with formed frust keratoconus who's also seeking glasses independence and used as a mini monovision lens in the way that Alex has described. So this patient would normally not receive a diffractive lens in my practice, a diffractive multifocal lens in my practice, but is functioning independent of glasses at the moment because of the use of the IC-8 as a mini monovision lens. I also find that I completely agree with your point, Alex, that there are patients who you really want to jump and do a YAG at a very early stage because a small amount of opacity in that you've isolated a very small window of vision. I make a good attempt to clean the capsule, polish the capsule, do a cortical cleanup and a quite equatorial cleanup at the time of cataract surgery so that you're delaying that YAG as long as possible. I've tried both a circular YAG outside of the optic zone, but I tend now to favour a small cross pattern within the small optical zone in the centre. I'd be interested to hear what the other panellists like to do. The other tip I would give is that you've got to be careful going near with your YAG shots near to the edge of the optic. You can leave those white pitted marks that you can see on this photo here if you're not careful. DMEC patients are increasingly, or Fuchs patients are a category of patients who are increasingly able to deliver better and better refractive results for. But still, you know, a phaco DMEC is a refractively unpredictable procedure, and often to get some predictability, it's better to stage the surgery doing a DMEC first, because I find, especially in low to moderate toric powers, you're not quite sure what that cornea will do once it's detergessed and has adopted its post-graft shape. And a phaco DMEC combined with the AcuFocus is giving me, in 2 patients so far, a small cohort, some pleasing results, because it's again that wider landing zone for refractive for astigmatism when you're not sure of the axis, and for a hyperopic shift that you can guess but not be completely sure that in terms of its magnitude. It's been a useful lens to combine with DWEC or DSO surgery as well, both because the patient only has to, it minimises the zone that the patient has to clear, and isolates that central zone that can be a source of irregular astigmatism in the early post-operative phase after DWEC. And there's a patient who had 6 weeks post-cataract of DWEC in the left eye with 6.5 N5 vision. And to tell a patient with fixed dystrophy that you can deliver that without a transplant is very pleasing. I had high hopes for this lens post-radial keratotomy, and it's worked well for me on one occasion. I just haven't had the chance to do too many of this, put too many of these lenses in that scenario. Some years you seem to get lots of them, and just in the last 12 months we haven't had many. But I'm sure that that's another solution, another category of patients I think would be well served with pinhole optics. Those are all the points I want to make. I think that's enough for the webinar tonight, and I'll happily answer any questions and then hand over to Jod.
Great. Okay, thanks, Greg. Just some of the points that you brought, I think just worth discussing. Just Alex as well. Greg mentioned about cartridge. I mean, I agree. I use B cartridge as well. I haven't actually seen that, Greg. I have to say that orange. Well, after you showed it last time, I went back and checked a lot of my pages, and I still didn't see it. Recently, we've not been able to use Alcon cartridges because there's some issue, and I've been using, I think, the Sovereign, which is the one that the Allergan, J&J lens, the Zebu goes through. And that seems to work absolutely fine. So all the recent implantations that I've done have been using that cartridge, and it works just as well as with the SA60 cartridge as well. Alex, what cartridge do you use?
I use the B cartridge. Yeah, I haven't seen any folding generally. I understand.
Too rough.
Above, I think it's above 25.5. You need to use an A cartridge. Yeah, I'm very obedient. I tend to use what's been asked. Yeah.
Okay, great. And Greg, one of the points about centration, I mean, I think centration is actually quite important actually with this, because of course you minimize the aperture down, and anyone where you're going to get a variation in centration, I mean, that I think can be a bit of an issue with this as well, especially if you're doing it in a little bit more of a complicated case as well. So that's interesting to see. And I mean, to me, the centration in cones probably seems to be a little bit more difficult compared to doing it on a standard case. Any comment on that?
Absolutely. I have. It's very hard to know what's the. I have to admit to having no secret there, Jod, because it's very hard to know which where we in a keratoconic what we're actually doing is centering it on the pupil.
Yeah.
And then we're performing topography, go to PRK, centered on the corneal vertex.
Yeah.
And then we're just hoping for the best. And if the visual axis in keratoconics may actually be something that is plastic.
Yeah.
And we all know that there are patients who probably isolate a small zone to choose with their vision, either with some sort of angulation of the eye, or something more physiologic like a photoreceptor alignment. But for cones, we just put on the pupil center. Okay.
So just one question from the chat box for Alex. Alex, just talking about IC-8 distance vision. One of the question is that should it be, I think you covered in your talk, should it be on par or superior to monofocal lens for distance? Bearing in mind you're setting it for 1.25 for nearer in your talk.
No, we're actually not. I mean, I think it's a bonus that they see quite well for distance, but it's really just going along the theme of monovision, and that's why I've targeted a little bit more, because traditional monovision is minus 1.5, where patients can tolerate the nisometropia, and so I've used that theme and just and really targeted good near vision, expecting a drop off in distance vision. So it's not on par, but surprisingly, some patients do see 6.6 unaided through the IC-8 for distance, but most see probably about 6.9, 6.12.
Great. Okay, great. Okay, thanks, guys. So I'm going to give the last talk. I'm just going to share my screen. Okay. Okay. Okay, this is, we can see this? Yeah. Yeah, okay. So I'm going to be talking about lens-based management of irregular corneas, and then I'll introduce this and then talk about where our experience has basically been with the IC-8. These are my financial disclosures. So just a little bit on definition, I think, which is important to basically understand, or basically what is irregular astigmatism. And there are two types basically classified really by computerized topography. One is basically irregular astigmatism, where you're going to get unequal slopes of the hemimeridian. And the second is where you're going to get pure irregular astigmatism, when the computerized topography cannot demonstrate any recognized pattern. And I think that it's really important to ascertain exactly what your patient has, because you've got to bear in mind, you're trying to correct a symmetrical effect of irregularity with the lens. And if it's truly irregular, then you're going to get some under or even some overcorrection in one of the hemimeridian itself, or it may not be possible to correct in any of the hemimeridians as well. And you need to basically counsel the patients beforehand on this outcome itself. And of course, keratoconus basically springs to mind as one of those obvious features. If you look at the causes of irregular astigmatism, obviously we can divide them into primary and secondary. Primary, I think, quite uncommon. Secondary is mainly related to all the ectasias. and basically most of the sort of refractive corneal surgical procedures, such as PRK, LASIK, RK, and AK. And obviously, as Greg mentioned, any sort of corneal scarring on the ocular surface can lead to irregular astigmatism, and this will need to be dealt with in the appropriate manner, as opposed to tackling this from a lens-based approach. But you may get somebody who has a residual scar with induced astigmatism post-tritium surgery that may warrant the use of a lens in that situation to reduce the effect of the astigmatism. So when we basically look at irregular astigmatism, I mean, I seem to see it quite a lot, I have to say, and I think that we can take an analogy from COVID. If you don't look for it, you probably won't find it, or you won't basically have it itself. So I think the more you look for it, the more I seem to see it. And I think it's important to ascertain this pre-op to exclude all the patients that are going to be unhappy, say if you basically put a trifocal or some sort of multifocality lens inside the eye itself, because certainly if there's any level of irregularity, they're going to be unhappy with the result. The treatment is normally basically set up with contact lenses, excimer-based treatments, typically topography guided, and of course lens-based treatment probably can be used in combination with the above, and then you have to think about your lens-based selection. And you have basically two combinations of lenses, either basically putting a phakic lens, of course if it's a young patient that doesn't have a cataract, or in older patients, either a toric lens or basically a monofocal lenses. And the examples I'm just going to really stick to is more refractive surgery today. So more refractive cases, typically RK, and then obviously IOLs in laser refractive surgery. And I'll show you some of the differences basically between dealing with these cases. As I mentioned earlier, it's really important that you're basically trying to correct the same power in each hemimeridian. Hence, there will be some residual undercorrection inevitably itself. So really trying to ascertain the glasses visual acuity, especially if you don't have a cataract, is basically more ideal, not the contact lens visual acuity, which will be superior. So it's important that you cancel this beforehand. Now, in a cataract patient, this is a little bit more tricky because, of course, the patient may obviously have reduction in visual acuity from the cataract. So ascertaining what that is will be a little bit more difficult to do as well. When you're assessing patients, I think it's important to do the right topography as well. So you see over here on the left-hand side, this is an orb scan of a patient done in basically 0.5 diopter map. So you can see there's possibly some irregularity on the surface, but you can see all the area over here in pink, which is basically 49.5 diopters. Now, if you look on the right-hand side over here, you'll see the astigmatic value is about the same, 8.3. But now it's a little bit more clearer to ascertain that you can see there is actually some irregularity over here. But interestingly, this patient was referred to me, and it initially was put in the notes as a regular symmetrical oblique astigmatism. So somebody was thinking maybe we can actually put a toric lens in the situation to balance out the astigmatism. Now, in fact, both these scans are actually from the same patient, and what you probably all notice is that all the differences is that we changed the half diopter steps to basically 1 diopter. So I think if you're dealing with higher levels of astigmatism, you need to go back to 1 diopter steps to really see what's going on. 0.45 diopters is great for your pre-LASIK assessment to see things in a normal cornea, but it's not good when you're basically dealing with abnormal corneas that you're thinking about doing some sort of refractive component on it, especially if the astigmatism is high. I basically prefer to use shine fluid imaging, and this is the same image now done basically from that patient over here. And clearly with the shine fluid imaging over here, you can actually see the difference in the hemimeridian is actually much more than you actually think. And it's actually almost 6 or 5.6 diopters across the hemimeridian on this side, 2 diopters basically on the other side. So instead of undergoing for a toric lens, I did a variation selective, basically AK for this patient, first of all, to try to basically reduce this asymmetry of the astigmatism and try to basically get the surface a little bit more even before they undergo cataract surgery as well. So it's important, I think, that you get good imaging done, first of all, so you actually understand what's going on in the corneal surface before you undergo basically lens-based surgery. This is just another example of a patient that was just recently referred to me, similar to basically Greg's case. Again, we sent because they thought I could do an IC-8 for this itself with irregular astigmatism. And of course, this is basically what the eye looked like. This is a patient with bullous keratopathy with CMV endotheliitis. And of course, he's being listed for a phaco-DMEC. He's not going to do you're not going to do anything with this with any typical lens-based surgery. You need to basically control the edema, and that will basically clear up what you're going to see on the topography. So it's important to ascertain what you're basically looking on the scan and what you're basically seeing on the patients as well. So I'm just going to show you this initially a case of a 70-year-old Chinese gentleman. He's a retired doctor. He had bilateral RK done in 1996. On the right eye, he basically had 4 cuts. Left eye, he basically had 8 cuts. The visual acuity dropped in the left side, 645. This was basically his refractive correction. Right eye basically was 621. Left eye, basically he wants to have cataract surgery. He's actually basically left eye dominant. And if you look at the cut, the spacing actually was done pretty well. And on the right-hand side, of course, he only has 4 cuts on that side. Again, if we look at basically the topography, you'll see on the right-hand side, it's actually quite even with respect to his ocular surface. Okay, so this is quite an even space over here, minimal amount of basic astigmatism, of about 2 diopters. On the left-hand side, interestingly, he also had quite an irregular surface itself. So even though he had irregularity from the cuts over here, the asymmetry is actually pretty minimal. It's only basically half a diopter. So this is the kind of case where I actually would be a little bit more confident if I'm basically going to put a toric lens in. In fact, that's exactly basically what we did. I did a toric monofocal for him, and he got a very good visual acuity result basically post-op. But these are very few cases, and I'm basically using the topography to guide me with respect to what kind of lens choice I will do. If there's any doubt that the asymmetry was basically too much over here in his dominant eye, I would have just basically put a monofocal. But he's quite an exception with that to basically get this kind of result. You also have to bear in mind that, of course, there will be some spherical aberration induction from your refractive surgical procedure. So it's important to warn the patient with respect to quality of vision afterwards, because he's still going to have the positive spherical aberration from the refractive surgery as well. This is another guy, a 58-year-old gentleman, slightly younger. He had a higher degrees of myopia, and he had bilateral arcade in the right eye in 1990, left eye in the same year, but left eye he had 8 cuts, right eye he had 16 cuts, and you can see the symmetrical 16 cuts basically on that side. Subsequently after that, he had, I presume because of the irregularity, in 92 he had P-arcade done on the left eye. On the right eye side he had LASIK, and then he presented to me with blurring of vision with bilateral cataracts. Now you would presume, if you look at this and you're going to do basically cataract surgery, you'd think that basically actually this side over here should give you a bit more irregular surface compared to basically this side on this side, because of course there's more cuts and they look quite evenly spread out on the corneal surface. However, when you see the topography, actually the story is slightly different. If you look at the right side over here, of course you can see he's got quite a lot of flattening on his ocular surface over here. So he's got a bit of a hyperopic shift basically on the cornea. But you can see the central cornea, the central area, actually is quite regular. Okay, he's got basically about almost a 2 diopter or a diopter and a half shift across the central surface irregularity itself. Okay, now on the left eye, the one that has less of the arcade scars over here, you can see that across the hemimeridians over here, he's almost got a 26 diopter difference. Okay, so in this situation, you're not, if you're going to basically do this with a lens-based approach, you're not going to basically obviously put in a toric lens over here, because you're never going to be able to correct this hemimeridian across the surface. And irrespective of what lens you put, even if we reduce this down to a 1.6 millimeter aperture, because each hemimeridian has almost got 20, it's got 20 diopters across the hemimeridian, you have to basically counsel him with respect to your refractive outcome over here to get him a visual acuity that's going to basically be useful, that he's going to get a lot of aberrations and effect because he's got a lot of variation, even in that 1.6 millimeter zone, if you look in the central area, if you do a small aperture optic. Now, again, if you look at his spherical aberration, he's got high levels of spherical aberration in both eyes, of course, higher in the left eye compared to the right eye. And you probably think that maybe his excimer ablation on the left eye was probably a little bit decentered over here, and he's got a little bit of irregularity from that, which explains why you basically have this deficiency with respect to his outcome on the ocular surface. So he underwent cataract surgery, and on the right eye, he got a pretty good outcome. He ended up plus 0.75 or with -2, 6.9. And of course, you basically expect this because his basically surfaces, even though it's pretty flat, actually it's actually quite even. So of course, unfortunately, I had to do the other eye where you've got a huge level of irregularity. And when he had the surgery done on this side, eventually we got him basically over this. But I have to tell you that we did warn him, because he did get a hyperopic shift in the first calculation. I did an IOL exchange for him to basically get him to this level itself. But it is really difficult with this level of irregularity across the central aperture zone to get him basically any better than this, especially, and you have to obviously warn them with this level of irregularity, regardless of what formula you're going to basically use, there's going to be basically an error that's going to be carrying, and they might have to undergo a secondary surgery to basically correct that as well. So IOL calculations in irregular astigmatism, I think is quite difficult itself, and basically it is a real issue. And you're basically providing, the problem is you're providing assumptions when you're looking basically in the small, basically central area itself. And of course, you're trying to ascertain that the measured K is equal to the K at the visual axis, and that's ideally where you basically want to center the lens and where you want to put basically the accuracy of the lens itself. Most of the calculations have not been validated in patients, say, with ectasia or those with keratoconus. We do obviously have better formulas now. For most of the refractive corrections, I do use Barrett True K, which seems to be one of the better formulas with respect to basic outcome. If you look at studies that studied looking at refractive lens exchange for basic patients with keratoconus, almost 26% of eyes had to have a lens exchange due to basically an error of greater than 1.5 diopters, okay, and 6%. And this was even done basically, and one of the things that people are advising is trying to use intraoperative biometry or intraoperative refraction to help you basically ascertain that you're going to get an improvement in your visual acuity results. And this was reduced to 6% using intraoperative biometry. How do you basically do the imaging? I think Scheimpflug is a pretty good way of doing it. The repeatability is better if the K readings are less than 55, but I do try to get multiple images done to basically improve on the outcome. And I'd probably use a couple of machines to really get accuracy. You do need to be careful. I see a lot of patients, still people using orb scan. Some people don't even basically use that. They use the K readings from the IOL master. And I think if you really are tackling these kind of cases, you really need to see what is going along on the whole ocular surface and not just in the IOL master readings in that central basically zone itself. But you're basically looking for repeatability of your accuracy of the surface itself. As the case I showed you with a toric lens, I do only use it in mild forms, and it's really related down to the irregularity on the hemimeridians and also basically looking at your aberrations. Okay, if you get somebody who has reasonably low aberrations like that guy had, and a relatively regular surface after a refractive procedure such as RK, then you're probably going to be lucky that actually you find that person, because then he's going to be applicable for a toric lens and he will get obviously a good unaided visual acuity result. The other thing to ascertain is basically whether it's an ataxic case or somebody who's had a transplant is basically whether the patient is going to use an RGP lens after basically the surgery. Of course, if they're going to use an RGP lens, do not basically put a toric lens inside the eye. If you do that, basically you will not be able to neutralize the effect of the toricity of the lens on the ocular surface, and then need to wear a bitoric RGP lens in order to basically get around that, which can actually be quite difficult to basically obtain for most contact lens practitioners as well. So if you basically want to be safe, just basically put a monofocal in as well. There are some reports of basically using trifocal lenses, even in patients with ataxia. I would never basically use it. It's not because of the issue with necessarily with the fact that I don't think you can basically neutralize the astigmatism, but I worry about the spherical aberration and the coma as well, especially if it's keratoconic. But there are reports in the literature itself, but it's something that I would never basically venture to do as well. So really what we're looking for, the challenge is really looking for an alternative lens that will provide depth of focus, reduce the aberrations in these aberrated surfaces themselves. And one of the concepts, as you basically heard from the other speakers, is by using these small aperture optics to help you with depth of focus. And the idea is you get an extended depth of focus. You can basically get a little bit more tolerance to astigmatism, okay, and a little bit more resistance to higher order aberrations. And we know when you're dealing with these cases, especially post-refractive surgery, there can be an induction of higher order aberrations to try to neutralize basically these effects. So I'll show you a few cases of basically where we've used this lens in patients who've had irregular surfaces on the cornea itself. So this is the first guy. He's a 66-year-old Chinese gentleman. He had basically a left herpes simplex scar that was quite inactive. His left eye basically irregular symptom, his right eye basically dominant. So you can see the irregularity on the surface. He has about almost 8 diopters or 9 diopters of regular astigmatism across basically the ocular surface. This is basically his old hepatic scar that's actually quite quiet over here. So he underwent basically IC-8 implantation. So I always use flax for my cases because I think that centration is basically important. And I think I do vary the capsulexis in relation to the visual axis basically pre-op. And I think that will allow you to at least get the lens well centered because you're only looking for that 1.6 millimeter aperture. As Alex mentioned, his distance to the acuity wasn't too bad, 612 plus 2, so it's acceptable. This is at 1 month. His intermediate vision was NA, his near vision is NA, and his other eye, because he's got a monofocal in that side, his binocular vision is basically pretty good. At 3 months, he basically pretty much stabilized. His distance vision acuity is quite good. He had some surface issues with lubrication, so I basically gave him some plug. And he's maintaining both his intermediate and also basically his near vision. And like the rest of the guys said, I do counsel him about basically practicing his near vision in basically good lighting conditions to keep his pupils round. But it allowed us to tackle this problem, which would have left him with an undercorrection. Certainly, if I try to put a standard toric lens in, which I probably would never have done looking at this versus surface topography profile. And also the interesting thing is you look at his scar over here, it's quite mild, but you look at the amount of irregularity is inducing on the ocular surface. So you can easily get misled when you see these patients basically on slit lamp, but this is using sporadic shadow to really show up the scar as well. So it's always best to have good topography. So this is a more conventional case. It's a lady who's a dentist from Malaysia. She had hyperopic LASIK some times back. She's a patient with bilateral Fuchs, which is quite stable. She got pretty good cell count, and she had bilateral cataracts. Her right eye is basically dominant. So I did the right eye basically first for her, and I basically put in a standard monofocal lens. She had an SA60, which you can see on the spherical aberration. She's slightly minus, so I put a positive spherical aberration lens in basically for her. The left eye, she underwent IC-8 implantation. At 3 months post-op, she got a pretty good refractive basic outcomes. Again, she's about 6'9" for distance. I aim for basically to leave her about minus 1.25 on biometry. Intermediate vision is M5, and near vision also pretty basically good. Binocular vision, she holds quite well, and she's just basically using ocular lubricants. I asked her, what does she basically do for most of her work? Most of the time, she's spectacally independent. When she does root canal, she tells me she wears some loupes for the eye, but otherwise she's pretty much spectacle independent from there itself. Okay, what about the opposite here? So this is a typical scan of a patient who has basically had myopic LASIK that you'll all basically be familiar with. So myopic LASIK 10 years previously, he's now a 59-year-old. He has a history of basically NTG. His highest IOP in the notes has been 17, and he's stable on basically on ASOP. So you have bilateral cataracts again, right eye basically dominant. So you can see typically he's got positive spherical aberration now, basically on his scans over here, and you can see the typical myopic ablation basically profile on both of the shine through imaging. So the right eye here, we used a Zebu lens. His unaided vision acuity was pretty good for distance vision. Left eye underwent basically ICA, and 3 months post-op. I'm roughly aiming for about 0.75 to 1 diopter under correction. He's pretty good for intermediate, and he's also pretty good for near as well. So this is, to me, this is an advantage where, as opposed to doing standard monofocal, where I may get him pretty good for near vision or maybe intermediate, he's actually getting distance intermediate and near, which is pretty reasonably acceptable just from basically the eye that's had the ICA implantation as well. And it obviously is still on lubricants, which is quite important in these patients because they often get issues with dry eyes in the long term. Now, one of the issues that we discussed with the glaucoma people is what about the assessment for basically the optic nerve at the back of the eye? And you can see this fundus photograph is pretty good. You can basically do serous, basically OCT at the back of the eye without seeming to be having any problems. And this is just a blown up picture of that same thing. And they can even, there's no issue basically examining the macula using GC IPL, interplex formulary analysis, and also basically looking at the optic nerve head. So anybody that needs to be monitoring for glaucoma, I don't think it's necessarily such an issue. And there's a paper recently where it seemed to be okay about doing basically retinal surgery as well. So that doesn't seem to be a contraindication for use basically of this lens as well. Okay, and this is just basically undergoing basically visual fields as well with the same disc photos at the top for stereo disc analysis. The last case I'm going to show is another LASIK patient. So this was slightly different in fact that you can see the ablation is slightly more decentered over here. Okay, and the left eye is basically his dominant eye on this side. And again, you can see even slightly higher levels of basically spherical aberration basically post-op. So the left eye, we basically put a monofocal IOL, so you got pretty good unaided visual acuity result. The right eye, he had basically a flax with an IC-8 in. And again, you can see pretty reasonable distance vision, intermediate vision, and also near vision as well. Okay, and again, pretty reasonable result. Still has to use a lot of lubricants basically on the surface. If you look at the KR1W to look at the effect of the lens over here, and you look at basically the internal effect on this side over here compared to the cornea, you can see how the spherical aberrations on the ocular surface have been negated by the negative effect of the spherical aberrations in the right eye that's basically coming from the IC-8 lens. And that's basically the effect of the pinhole, basically neutralizing the effect of the spherical aberration. So that's showing you the effect that, as I mentioned on the slide about 3 or 4 slides ago, about trying to reduce the amount of aberrations or aberration, I wouldn't say aberration neutral lens, but certainly trying to reduce the amount of aberrations of the lens itself. So in conclusion, lens-based surgery is good for mild to moderate amounts of irregular astigmatism. Of course, as I mentioned, you always have to think about how you're going to correct basically hemorrhagium. You will not get full correction of astigmatism, but you will get a reduction by 60 to 80%. In keratoconus, you need to consider disease progression first, and of course, you need consistent basic topographies and refraction. If the preoperative difference between the best corrective visual acuity and the RGP contact lens spectacles is high, the lens-based treatments may not be suitable, or the patient needs good counseling about what's going to happen after they've basically done their cataract surgery. I think you do need to assess every case individually, and there are no really magic bullets that one thing will basically treat all, but you do have a degree of tolerance, I think, with the ICA, but understanding that topography pre-op, I think, is basically very useful as well. So I think IOL selection is important, obviously depending whether you're going to have basically previous hyperopic correction or basically myopic correction, and respect to toricity and your contact lens basically contact lens tolerance post-op. The new generation formula, generally I use Barrett True K for basically all the refractive basically cases to improve the outcome, to get basically more accurate results. And I think you do get a degree of tolerance with respect to what you're aiming for when you're basically using this lens in the non-dominant eye. Thank you for your attention. Okay. Any questions, guys, from anyone on the panelist? Any questions? Greg, Alex.
Jod, what's your preferred method of YAG capsulotomy in the IC-8?
Yeah, so I've done a few. I dilate them as maximally as widely as I can, and I'll laser outside the area. Okay, but I mean, I see the point about, you know, waiting. I think, you know, I've seen cases where I think I agree. I think so what you said about getting that whitish area. Certainly, if you do hit the AcuFocus implant, you will get that little whitish area around the area as well. So I try to tilt the lens, try to go out peripheral as I can to basically get that tear in the capsule, basically. So I try to go as wide as I can as possible out there, and then basically fire around like a half horseshoe, and then it basically fall back.
Yep.
There's one question over here. They answered that. We answered that already about the visual acuity results. What the thing? I think that, I mean, you know, I think that the LASIK cases, I mean, certainly the refractive cases and RK cases are extremely difficult to get them to have distance intermediate and near. I've always found that very difficult. And the best I've always been able to do is basically monovision. And I see this quite nicely fitting into an area where we don't really have anything, and most of the trifocals and certainly the EDOFs. I don't know if you guys have experience using EDOF lenses in this group of patients and how they fare in comparison. Greg or Alex?
I don't. I traditionally, Jod, I like you. I've strayed away from EDOFs and diffractives in irregular corneal patients.
Yeah.
This is. I mean, we're playing around with Vivity now, and we'll see what that can do. But I think that, you know, I think that we've got an elongation of your sort of your focal point from the cornea, and then you're elongating it again. I like the idea of the, but basically this lens is slotted into my practice, or pinhole optics are slotted into my practice for these patients. I don't see a lens that I'm going to above that at this stage in the game.
Yeah. Alex, have you got any experience with EDOFs in these like post LASIK patients?
Yeah, I tend to stay away from EDOF and diffractive lenses just for the same reasons.
Yeah.
Yeah.
Okay. Great. Okay. Any more questions on the from any of the audience? I think you guys have left them speechless. So, okay. So I'd like to thank. There's one question. Let me come up with a question here. Any experience, Greg, with post-presbyopia LASIK cases, or any experience with decentration of this lens?
I can speak to no experience with post-presbyopia LASIK, but I do have a decentered case that we had to take back to theatre because there was what happened? There was optic prolapse at one edge of the capsule, some fibrosis in the capsule prolapsed, and the lens began to tilt, and
okay.
I had sort of I had to reopen the capsule, place a tension ring, and center it again, and that has happened to me in one case. And that was successful. I saw him only 2 weeks ago, and that's been stable now for quite a long time, 6 months. Jod's point about flax and making sure you got the capsular axis right. If you don't have flax, which I don't use flax, but you have to be very careful about thoughtful about where you're putting, what you're doing with the capsular bag in this lens, just like you do, I think, with every specialty lens that is dependent on centration and tilt.
Okay. Alex, just one question for yourself. How long do you keep them on mitotics for if they're getting glare effect?
I don't have the answer to that. The patient that I've started on is still using it.
Yeah.
I'll probably try it. I would hope that if there is capsular fibrosis around the outside of the opaque disc, hopefully that would help reduce the stray lights coming in when the pupil dilates. So maybe try for 6 months. And I guess that's one of the reasons why I would aim for capsulotomy through the small aperture rather than around the edge, hoping that capsular fibrosis will help the opaqueness. Yeah.
I mean, I only have one guy that I've given it to, and he's once he noticed the effect of the thing, he actually started just using it at nighttime. And so now I said, do you use it every day? He wants to use it as a social thing, basically. So he only does it whenever he wants, basically, and stuff. So he doesn't really even do it all every day, but he has it with him.
Yeah, my chap uses it when he drives at night.
Okay.
I've got a question. Do you have a favorite orientation for this lens? Like, do you always insert a certain way, or?
I mean, I always end up putting the haptics at 12 and 6, but I'm not sure if that's that's probably by randomness, by more than experience, I think.
Great. Does one orientation center it better than another?
I find that I play around with the centration software and then see which haptic orientation allows me to hit that better, and it more often so far has been sort of a 6 and 12 for me. More often the pupil, as we know, is going to be probably a little bit supranasal in most patients, and if you've got your haptics pointing that way, it can be hard to shift the lens over, the optic over. But so that's mostly what I do.
Okay.
Great. Okay. Thanks, guys. Thanks very much for the participation and talking today and sharing your experience with the IC-8. I'd like to thank AcuFocus for the organization for this webinar, and I wish you all a good evening and hope to see you in happier times at the beginning of next year. And I'll hold you to my bottle of wine, Greg, that you spilled over and stuff. Okay, great. Thanks, guys. Thanks very much. Good night, everyone. Good night.
Thank you. Bye-bye.